what are the most common knee injuries that you see?
We see a variety of knee injuries because there are a lot of ways to hurt yourself, obviously. But I would say that meniscal tears are the number one injury that we see. ACL tears, anterior cruciate ligament tears. Number two, within that, you also have other ligament injuries such as the medial collateral ligament. That's a little bit more common. A little bit less common is the posterior cruciate ligament and the lateral collateral ligament, or the posterior lateral complex as it's known. A lot of these injuries are from twisting and turning, so they're not necessarily contact injuries. We see a lot of overuse injuries, a lot of patellofemoral disorders. That's when the kneecap doesn't track appropriately. You get a lot of pain in the front part of your knee. Patients will complain about pain when they sit for a long period of time, particularly with their knees bent, going up and down stairs, running hills. We get a lot of runners in New York. I think it's helpful that I ran 2 New York City marathons. I was just lucky I didn't get injured, but there are a lot of pitfalls to overtraining and overuse. And I think it's helpful when your doctor knows that he may have actually had those injuries as well, and how did I cope with those.
Nice.
Wonderful. You're an excellent.
Oh,
You're
thank you.
So much easier for me. You really are.
Yay!
Just don't lose the audio.
Please. So next I want to go over shoulders,
Sure.
as I see that a lot of people do search for that, and we get a lot of booked appointments for shoulder injuries, pains, and aches. So I'm going to ask the same question. What are the most common shoulder injuries? Or
That's fine.
Good?
Hold on 1 second. Wait for this truck to pass.
I also want to see because I have my little list here.
Oh.
Okay. Dr. Lager. Yeah,
you're good.
Dr. Lager, what are the most common shoulder injuries you see?
I would say we see a lot of overuse. So that will do. Sorry, start again. See, you complimented me, now I messed up.
Bam!
Flubbed it. Flubbed it.
All right. Boom, boom. Olivia, stop. Dr. Lager, what are the most common shoulder injuries you see?
We see a lot of overuse injuries, particularly in overhead athletes, such as tennis, or we see with some volleyball, basketball, anything where it's overhead. A lot of falls. A lot of people fall worse, I think, in the winter. And with that, you'll get more traumatic type of injuries, such as a labral tear with a shoulder dislocation, rotator cuff tear. We do see some osteoarthritis, particularly in some of our overhead activity athletes. Biceps tendon inflammation. Those are the main injuries that I see for the shoulder. So you're going to say, so how would you treat a rotator cuff tear, Dr. Lager?
Okay, so we're going to keep, All right. Ready? Dr. Lager, how would you treat a rotator cuff?
Tear.
Sorry. Yes, because a lot of things can happen to your rotator cuff.
So maybe you should say something like, I think I tore my rotator cuff. How would you help me with that? What would I do?
What would you do if I tore my rotator cuff?
First thing, we'd bring you in, because there's nothing like seeing a patient, not doing it over the phone or internet. I think it all starts with, how did you hurt yourself? Understanding the mechanism of injury is very important. Understanding what you do is a lifestyle, what you do for work, what type of activity do you do is also important. So we try to get the intake first from the patient, understanding who they are, how they hurt themselves, and what their lives are like. Second is a physical exam, being able to evaluate your strength, your range of motion, some other tests called impingement tests. Sometimes when you have an injury such as that, it'll send pain to the outside part of the shoulder, so it's not specifically in the shoulder where you're having pain, but it can be referred pain. Doing a neck exam also is very important, just to make sure that you don't have any cervical pathology, which can also mimic shoulder pain. X-ray is the next step, and we have that in our office, digital X-ray, so we can see it very quickly with a very nice image, so that I can review that with you and then talk to you about what other issues you may have, such as some arthritis inside your glenohumeral joint, which is the ball and socket joint. You may have some arthritis in the AC joint, which is on the inside part. And then we would talk about imaging. MRI is really the choice study to evaluate what your muscles look like and if you have a tear. Just because you have a tear doesn't mean we have to run to the operating room right away. Many people do benefit from doing physical therapy first. Sometimes a cortisone injection can help with the inflammation. But it really depends on the size of the the type of the tear, and the complexity of it. Some patients do need to go to the operating room right away, and we would manage that surgically through arthroscopic portals, which are very small incisions, a camera, which allows us to see the entire shoulder without having to do what was considered the standard a long time ago, which is an open procedure. Some people still make a large incision and do open procedures, but we do all our arthroscopic repairs. In some instances, if you benefit from the physical therapy and the injection, then you can go about your business, and we're hoping that you can regain all of your functionality and go back to everything that you did before. In those instances where we do have to operate, it will take about 4 to 6 weeks in a sling where you're completely immobilized to allow for some healing. And then we do physical therapy for about 4 to 5 months, and that's usually enough.
Say that one more time.
Which part?
The physical therapy for 4 to 5 months.
Sure. After you've had your surgery, you're immobilized in a sling for about 4 to 6 weeks, and then you do 4 to 5 months of physical therapy. And at that point, you're probably as good as you're going to be, and we're hoping that's close to 100%.
I'm loving this.
All right, thanks, man.
But energy.
More energy?
Maybe a smile.
A smile? It's
Throw
tough.
a smile in there.
I when I saw the other one, I was like, God, man, you're so monotone and you're like a stone. I will try.
All
You want me to redo it with a little more flair?
Well, we
Here?
can. Well, everything moving forward, we're gonna run
All
through
right.
some of these again, so you can kind of mix up.
Right, serious with.
Well, because when we do also the
With
anatomy,
Stoogie?
he's
Yeah.
going to go over the shoulder again.
Sure.
To kind of demonstrate it. So
All right,
we'll-
But-
do you want me to do some of that again?
We're gonna, like I said, we're gonna revisit a lot.
All right,
of it.
fine.
Alright.
Take
to
a
have
trip.
Different takes.
Take a trip. So you wanted me to talk about knee surgery?
Knee surgery, please.
All right, so say my husband just tore his ACL. What's next for him?
Okay. Ready for me? Okay. My husband just tore his ACL. What's the next steps?
I would tell you that first he needs to come in. We really need to see him and make sure that there's nothing else wrong with him. I don't know how he got his diagnosis, but I'd be happy to help. First step is to come into the office, speak with the patient, get an understanding of the mechanism of injury, how they hurt themselves, what it is that they generally do in regards to work and play, activities and sports they like to enjoy, and what their goals are. In some patients, just because you tore your ACL, it doesn't mean that we actually have to do surgery on you. Some older patients, some patients that are less active, or those that just end up being more mechanically stable don't necessarily have to have surgery. But in most cases, that becomes a surgical candidate.
So we have shoulders.
But I could say, you want me to go on with that? Have them come in and this is what I would do?
No, because I was
No.
going to listen to a long video.
No, but it's just you splicing it up. I don't know.
It's better
So-
overshoot than to undershoot.
Yeah, he's not
Alright.
coming back.
Okay.
You're not getting me on a Saturday for a long time.
So okay, so you want to go back into it?
Or just ask me something about, so if he comes in next week, what would you guys do?
Okay.
What would happen?
If he comes in next week, what would happen?
I'd take a look at the knee. I would certainly talk to him. I would look at whatever imaging he's already had done, and we would do a physical exam. Generally speaking, most patients have a lot of swelling and pain and stiffness after they tear their ACL. And if they have instability, which is when the knee shifts, I definitely don't want that to happen. So we put them in a brace that allows them motion in the front and back planes, but does not allow for rotational instability. In many cases, I do not take patients to the operating room right away. The biggest risk with ACL reconstruction surgery is called arthrofibrosis, which is scarring. I definitely don't want any scarring in your knee because I want you to have all the motion you could possibly have so that when you go back to your sports, you have the best chance of returning to your prior level of function. And so we do what's called prehab. I didn't come up with a name. Prehab, pre-surgery rehab. And the goal of that is to improve your range of motion and strength and diminish the swelling so that the knee looks almost like the opposite knee. When you've achieved those goals, the knee is at its most beneficial point for surgery to limit that risk of arthrofibrosis.
Solid.
Alright.
1 second. Let me just double check the other